Hi, everybody, and welcome to Conversations in Interventional Cardiology. My name is Sahil Parikh. I'm one of the associate editors of SCAI and a faculty member at Columbia University in New York. I'm delighted to be joined today by Andrew Schwartz, who's about to be a physician, but is a fourth-year medical student at Yale, and Khanjan Shah. And we're going to talk a little bit about the diversity of therapeutic options for SFA interventions. And Andrew's going to present his recently published paper in JSCAI, and we're going to talk more about how meta-analysis can help us select devices for therapy. So Andrew, without further ado, I'm going to let you put your slides up and let's hear about your paper.
Great, thank you. So I'm excited to share our study titled Comparison of the Safety and Efficacy of Endovascular Interventions for the Treatment of Superficial Femoral Artery Disease, a network meta-analysis. So for some background, peripheral arterial disease is a significant cause of morbidity and mortality worldwide, and disease of the superficial femoral artery specifically is the leading cause of both intermittent claudication and chronic limb-threatening ischemia, aka CLTI. Endovascular revascularization is indicated in many patients with SFA disease, including those with claudication resistant to medical management, CLTI patients without adequate vein graft or who are poor surgical candidates, or those who just prefer the minimally invasive approach. And there has been a proliferation of new endovascular interventions within the past 2 decades, with numerous high-quality randomized controlled trials comparing the safety and efficacy of these therapies. However, it remains unclear how to apply these numerous randomized controlled trial data to real-world practice for our patients with PAD. And there's also a lack of specific device selection guidelines among the consensus American and European societies. Thus, this network meta-analysis was conducted using randomized controlled trials to compare endovascular therapies for SFA disease to understand how to best treat our patients with PAD. So for the methods, we conducted a search of PubMed for randomized controlled trials comparing endovascular interventions that had independent core lab adjudication of endpoints. We then conducted a network meta-analysis, and when available, PTA, or percutaneous transluminal angioplasty, was used as a common comparator. However, drug-coated balloon was also frequently used as a common comparator given its prevalence in many trials. The primary outcomes we studied were technical success and 12-month primary patency. Secondary outcomes included 12-month target lesion revascularization, 12-month Rutherford category improvement, and 12-month major amputation. So we did a traditional network meta-analysis, but given the large amount of comparisons, for simplicity in this presentation, I'll show p-scores, which aggregate information gleaned from the meta-analytic point estimates. And so these p-scores we used to rank order the interventions for each outcome. And finally, a meta-regression for variation of effect size by subgroups was conducted. So for the results, the search identified 57 randomized controlled trials with 9,089 total patients. Notable demographics of the cohort included a mean age of 68, 67 of these patients were men, 84% were white, 18% had chronic limb-threatening ischemia, 36% had chronic total occlusions, and 81% were de novo lesions. For the primary outcomes, overall, drug-eluting therapy performed well for primary patency at 12 months. As you can see on the right table of p-scores, BMS plus brachytherapy, lithotripsy plus drug-coated balloon plus bare metal stenting, and drug-eluting stents were highly ranked. For technical success, overall stent therapies performed well by p-score. As you can see, covered stent grafts and bare metal stents were ranked highly. So for our secondary outcomes and the results of the meta-regression, we found that 12-month target lesion revascularization, we found that drug-coated balloons plus bare metal stenting and atherectomy plus drug-coated balloons were ranked highly. For improvement in Rutherford category, drug-coated balloon plus bare metal stenting and drug-eluting stents were ranked highly. And for 12-month major amputation, this was limited by the amount of studies that were contributing to the network, but drug-eluting stents were ranked highly. And looking at the meta-regression for subgroups comparing the effect of drug-coated balloons versus PTA, we found that de novo lesions had greater benefit from DCB over PTA for both symptom improvement and 12-month target lesion revascularization in de novo lesions. Additionally, we found that women, as well as patients with severely calcified lesion, had greater benefit from drug-coated balloons over PTA for symptom improvement. So for some conclusions, overall, these data show that drug-eluting endovascular therapy and stents are superior to PTA for most SFA lesions. and this adds to the growing evidence that PTA alone for SFA disease is insufficient for most lesions. Additionally, we found that therapies with improved primary patency were associated with symptomatic improvement. And we also found that in highly calcified lesions, which remain a major challenge for those with peripheral arterial disease, showed that both atherectomy and intravascular lithotripsy are both viable options when compared against one another for vessel preparation in highly calcified lesions. And so overall, first-line use of newer endovascular therapies, specifically drug-eluting therapies and stents, are warranted based on the results of this study. Thank you.
Andrew, thanks very much. And I think it's important that we sort of put this in a little bit of context. The studies that you picked were the most rigorous in the space, and I think many would be surprised that we have 57 core lab controlled RCTs with primary endpoint data at 12 months. So I think that in itself, if we had looked at this maybe 10 years ago, the number of studies would have been less than half that. And so there's clearly been a escalation of interest in having properly controlled trials. What's your one key takeaway of your study in terms of what you think was both expected and novel?
So the key takeaway that we found, like I had mentioned in the conclusions, was that we found that drug-eluting technology as well as stenting was superior across almost every outcome that we studied. It was a clear trend throughout the study. And, over the past, 5 to 10 years since the innovation of drug-eluting technology has come to market and been used in practice, it's been used more and more. And I think there was a previous data that in 2020, I think it was used over 50% of the time. But and I think in the best CLI trial that was done from 2014 to 2019, PTA alone was still being used in about 20% of patients. And these are patients with highly complex lesions with chronic limb-threatening ischemia. So there's still improvement to be done in this space in terms of ensuring that providers and physicians know that drug-eluting therapy and these newer endovascular technology are the best way forward for these patients with SFA disease.
Yeah, I mean, I think the value proposition you've shown is clear, is that primary patency is superior with drug-eluting therapy. And I thought the adjunctive finding of using it, especially in de novo lesions, is really important to emphasize. If you wait till the first restenosis, the drug-eluting therapy is not as effective if you had used it in the index intervention. So Khanjan, as an endovascular therapist, you practice in Florida, and you work closely with the vascular surgeons at your institution. What do you see as clinical practice patterns, both in the community and in the academic setting? I work, like all of you, in an academic setting and in a hospital-based setting, but certainly in the ambulatory setting, we're now approaching 50% of endovascular therapy in the U.S. is done in outpatient facilities. There's differences in practice patterns. What are you seeing in Florida, and how do you think these data could potentially help improve the field?
Yeah, thank you for this. This is a very meaningful analysis. I think that, like many of you here, my practice is a lot of sort of second attempts or third attempts. And so these lesions are often already stented by the time I see these patients. One important thing is going to be sort of a cost analysis, in adjunct to the primary patency analysis, because as we know, newer therapies come with a cost, right? And so there has to be a value proposition for especially some of these outpatient labs to use this therapy. And studies like this do add value to that. So if you can prove that patients do better long term, even at an increased cost of novel technologies, then I think they're more likely to use it in these de novo lesions. I just want to point out that this is mostly a claudication study. 80% of patients were claudicants. And so I would be very, very careful to extrapolate this to CLTI, which is just a totally, different beast with multi-level disease. But, recently I've been trying to leave no stent behind in the SFA. I've sort of been, toying with that idea because of the number of times I see stents failed, and studies like this help me understand that perhaps when stenting is done correctly, it still leads to really great outcomes for patients, especially with adjunct DCB therapy.
Yeah, I mean, there's a number of interesting features of this analysis. The DCB plus bare metal stent, which is really, if you look at all the long segment disease that's treated in the real world, every registry shows roughly 50% bare metal stent, sort of bailout in those registries. So that's a real world population. And you showed really excellent improvement, both in primary patency and clinical improvement, Rutherford class improvement. And so that is, I think, encouraging of that paradigm that potentially can help in terms of what you asked, Khanjan, in terms of the cost effectiveness, because in the OBL, the mind of the operator is often fixated not just on cost, but on the cost of goods used in the procedure and their profit margin. And when stents are used, that can offset some of that potential loss that's perceived when using drug-coated balloon therapy. So I think the value proposition there is, in my eyes, very clear. And that is because the cost of restenosis and TLR is far greater than any upfront cost in just about any of these registries. We've seen that over and over again. And I think that you're right. If we don't put that forward, the regulatory authorities and the payers are not going to get the memo. And without that, we're not going to be able to change behavior in some of these ambulatory settings. Andrew, what else did you find was an increasing trend in these 57 studies? Was there a temporal improvement? Did you look at that as a possible confounder? For example, were trials done in the aughts and the early 2000 teens showing less efficacy than those in the later years?
No, we didn't really look at the temporal trend, so that's not something that, we studied in this analysis.
Yeah, it'd be something to consider, I think, as a subsequent analysis, largely because we've learned how to use drug-eluting therapies better over time. For one concrete example is that in the beginning, most of the instructions for use said to size drug-coated balloons, for example, 1-to-1. And the risk of that is that you could potentially undersize, especially if you're sizing by angiography and not intravascular ultrasound. And so if you don't have balloon contact, you're not transferring the drug. And therefore, the efficacy might be lost a little bit in those cases. So the more contemporary studies and the IFUs for the devices have largely been upgraded to balloon to artery ratios of 1.1-to-1 so that you get better wall contact with the balloons or the stents that you're using. So I do suspect that there will be improved outcomes over time as the field has gotten more used to properly deploying these technologies. Any other take-homes about adjunct therapy, atherectomy, IVL? Those are hot button issues. It sounds like in the studies that you looked at, they were used exclusively for calcium and not for other plaque morphologies. What do you think about that?
Yeah, so it's interesting that the comparisons were limited by the number of studies that we could include in the network meta-analysis. But when we did compare them, they were both insignificantly different for vessel preparation and primary patency. So I know studies comparing the two for highly calcified lesions are likely ongoing, but I think based on the results of our study, both are viable options for patients with more complex lesions that are highly calcified.
And Khanjan, you get the final word. I mean, you made a great point about the difference in the value propositions for claudicants versus CLTI. I mean, I was always taught that the metric by which we're measured for claudicants is patency, and for CLTI, it's limb salvage or amputation-free survival, or one of those endpoints. How would you put this in perspective for the lay operator out there?
I think that the main takeaway message for me is that if in a primarily claudication patient set, if you can achieve greater primary patency at 1 year, those patients will likely feel better long term. And these are the tools that are going to help us get there. I think IVL is so new that we have to wait and see how it's going to perform in this space. But other than that, I think that we have good data now, despite all the prior controversy, that DCB is going to help us achieve that goal and help these patients feel better. I always judge claudicants not so much on primary patency, but how they feel. But clearly, in terms of endpoints for analyses, primary patency is how you get there. So.
Right. All right. Well, I think that with this information in hand, the appropriate use criteria are being revised as we speak. And SCAI will be, amongst other organizations, publishing their findings as a new updated AUC in the coming year. So we look forward to seeing that document. I think their last AUC came right before the paclitaxel controversy, but was strongly endorsing the use of drug-eluting technology for femoral popliteal disease. I suspect they'll double down on that, but I don't know. I'm not on the panel, so we'll have to wait and see, and I'm sure we'll have another conversation at that time. So I want to thank you both for your time, and I want to thank our audience and readers. I will encourage you to go to jsky.org and take a look at our manuscripts there. And Dr. Schwartz, congratulations on completing medical school. And we look forward to having you amongst our colleagues in vascular surgery very soon. Thanks for joining, and we'll see you soon.